Thank you very much, Dr. Walid Al-Habashi, Dr. Ashraf Tayyar, for the invitation and for organizing this great webinar. I would like also to thank Professor Daniel Lichtenstein for his efforts in pioneering this modality. It's quite a daunting task and challenging to talk about something related to lung ultrasound after him. So I would like to thank him, and we all owe him a lot for pioneering this modality. In this short presentation, I will just shed a light on how we could use lung ultrasound to evaluate lung water and extravascular lung water, whether it is useful or not, and if it's useful, how to do that. It's going to be short, and I will echo some of other messages delivered by Dr. Lichtenstein and Dr. El-Tayyar. I have no disclosures. And the main question of the presentation, can we estimate extravascular lung water with lung ultrasound? So to answer this, we need to know what is the extravascular lung water. So the extravascular lung water is the fluid which is outside the pulmonary vasculature, whether it is interstitium or in the alveolar space, and it is dependent on the net outward filtration of fluid, and this is also balanced by the lymphatic drainage. So we all discussed and we all know the power of ultrasound in general and how it is useful at the bedside. It's easy to perform somehow to a limit, and it is quick to be applied as compared to other modalities. It has a relatively steeper learning curve, lung ultrasound specifically, as compared to other ultrasound modalities. It definitely reduces cost because you will probably require less chest x-rays, and you can also potentially do it and reduce the number of requesting CT scans. We are not saying it is a replacement of CT scans. CT chest remains the gold standard, but lung ultrasound is a very useful modality in this aspect, and therefore it can reduce the cost. And talking about the safety, it is much safer because it is radiation-free, and especially at the times of COVID, we all witnessed the pandemic and how we could avoid moving the patient outside the bed space and performing this bedside scan in a much safer way. So the equipments for performing the lung ultrasound, those are the different transducers, and it depends on the machine. I would advise you to be familiar with the machine that you have, because we don't always have the luxury of having different types of probes. Sometimes you only have a cardiac probe, which is the one at the top. You can perform parenchymal scan with it, but it is not the best. You can also use the curvilinear probe, which can provide a better image as compared to the cardiac probe for the parenchyma. And you can also use the linear probe for the superficial structures, looking at the pleura in high definition. But as Professor Lichtenstein highlighted, the best probe, if you have it, is the universal microconvex probe, which you can use to perform all these types of assessments. So starting with the first artifact that we could see when we scan our patient, when we want to look into the lung water, the first and best degree of aeration is the presence of Airlines, which means the pleura at the top, the horizontal line, and mirror-shaped artifacts at equal distance from the pleural line. This gives you the Airlines. And we need to remember that this could be also found in patients with pneumothorax, but if there's no pneumothorax, this means that the lungs are dry. The area of scanning is dry and there's no edema. And then we come to the important landmark seminal study by Professor Lichtenstein, when he described for the first time the cometil artifact, which used to be the initial or the first name for the B-lines. And the B-lines are described as vertical-like artifacts. As you can see here, they start from the pleural line at the top where the red arrow is. They go all across until the far field. They move with the lung sliding. They are long and well-defined. And the more frequent the B-lines are, the more tendency for them to erase the A-lines underneath. And therefore we can understand that the quantification of B-lines, or even the semi-quantification, can give us idea about the increase in the lung water. And those are another examples. You can see two types of B lines, and both of them have sliding with the pleura. And clearly those are the B profile as described in the B protocol, which reflects hydrostatic pulmonary edema. And this is a higher degree of increase in the number of B lines. And you can notice here that the color of the screen changes from the initial normal aeration of the A lines, which is more likely to be dark, to the gray shadow of the non-confluent B lines, to this shiny curtain-like bright pattern of coalescent B lines, or in other terms, it is the pattern that tells you that there is an abundance of B lines and they are fused together, making a curtain-like shape. And this is typical for patients with high degree of increase in the extravascular lung water. This can be used in patients with heart failure to monitor response to therapy, of course, to diagnose along with other modalities, and to assess prognosis and risk stratification. It can be used for patients after dialysis to assess the response to dialysis, whether they are effectively dialyzed or not in terms of fluid removal. And it can also be used in patients with non-cardiogenic pulmonary edema. And we all heard together that the increase in the lung water can happen in both conditions, whether it is cardiogenic or non-cardiogenic pulmonary edema and ARDS, which is one of the things that we could look into and see how we can differentiate by lung ultrasound. So we need also to remember that the number of B lines is important, not in the quantitative aspect of it, but we need to remember that you can find normally up to 2 B lines in one intercostal space. So we need to have more than 2 B lines in one intercostal space to say that this is an abnormal finding. And at the bottom of the screen here, you have examples of 3 abnormalities, 3 B lines on the left, 5 B lines in the middle, and a wide screen across, which is said to be almost 10 B lines. In intensive care, personally, I'm not into quantifying the number of B lines. I think it is more into estimating semi-quantitatively how high is the degree of lung water depending on the pattern. And those are the distinctive patterns of the 2 degrees of elevation in the extravascular lung water, depending on the number of B lines, from 3 to 5 B lines in one space, one intercostal space. We can say that those are named septal rockets. If you have more than 5, you can label that as glass rockets, which is a higher degree of edema. So this is bringing us into the concept of the different shades of lung water, or different shades of gray, as I may call it. So we have the black on the left, we have the gray, the black and white, and the bright white in the middle. You have the complete loss of aeration on the right side, which is the consolidation. So you have the air on the left, you have the lung water in the middle, and the consolidation on the left. And this slide is important because it shows us how we can use lung ultrasound as a monitoring tool to assess the responses to our interventions in the intensive care, whether recruitment, whether the response to diuresis. So it can tell you how to assess aeration and de-aeration. And then the next question is how to look into lung water in terms of differentiating cardiogenic and non-cardiogenic pulmonary edema. Of course, we don't use this in isolation. We have to use it in the clinical context. We have to use it with other ultrasound modalities, especially echocardiography. But there are clues on lung ultrasound that can tell us whether this is hydrostatic or non-cardiogenic pulmonary edema. We are more likely to see bilateral homogeneous involvement of the lungs with B lines in heart failure, with more predilection to the bases of the lungs, because the water tends to be moving down there by gravity. And you are more likely to see patchy areas of B lines in the context of non-cardiogenic pulmonary edema. When you look at the pleural line with the linear probe, you will look and see thin pleural line in isolated heart failure. And in patients with pneumonia and ARDS, you could probably see small consolidations anteriorly. And this is quite important because this can be used as a specific marker for pneumonia. And when we look at a pleural effusion, we know that pleural effusion is commonly seen in patients with end-stage heart failure. usually bilateral, sometimes can be more on the right side. It can lead to a degree of compression of the lungs or atelectasis, regardless of the mechanism. And it's difficult to tell the mechanism depending only on the amount of pleural effusion. But on ARDS, especially in the full-blown picture, you will likely see a degree of consolidation, which is the transformation of the lung into tissue-like pattern, where you could see the air bronchogram, whether it is static or dynamic air bronchogram. And here the blue protocol, which is an important tool that you can use at the bedside. It is a protocol developed by Professor Lichtenstein. It is useful in addressing the causes of an emergency presentation of hypotension or shortness of breath. And as you can see in the protocol here, that one of the two main diagnoses in the protocol cause elevation, the extravascular lung water. So again, this protocol can help you assess the evolution of lung water. So what are the different protocols for assessing the lungs? There are many protocols. None of them is clearly validated, but you can use the most straightforward and the simplest one. This is the simplest one, which is from the blue protocol, and it can give you high and accurate results, 2 anterior zones on the left and 2 on the right, and doing the PLAPS zone posteriorly. And this is another protocol which is widely available, and it is shown previously by Daniel, showing the 6 zones on the right and 6 zones on the left. Myself, I perform the 6 on the right, 6 on the left, but I'm very careful about what is labeled here as zone 2 and 4, because as said before, you can easily mistaken the abdominal organs, especially if you're a beginner in lung ultrasound. You need to make sure that you're above the diaphragm. So when I do it and I teach my colleagues and tell them about zone 2 and 4, I try to be as close to the nipple line as possible. And I always like to remind myself and my colleagues about the posterior zones, because the devil often hides posteriorly, especially in our critically ill patients who are supine. We need to try to get as lateral as possible to look posteriorly, because this is where we often see nasty consolidation in the supine patients. And this is a comprehensive protocol, which is mainly for research purposes, and it is used by our cardiology colleagues, where they assess 28 zones, 16 zones on the right, and 12 zones on the left. But this is not really practical, especially in our critically ill patients. So evidence. Now we can tell that the lung water can be reflected by looking at the sonographic sign of lung water. But what's the evidence behind that? This is one of the earliest studies which correlated the presence of B lines and the quantification of the B lines with the traditional thermodilution method for assessing the extravascular lung water, which is the PICO. So 20 patients before and after cardiac surgery. And as you can see here, there was a significant positive correlation between the COMET score, which is the B-line score, and the extravascular lung water as estimated by the PICO. So this was useful, but you can notice that it started initially in patients after cardiac surgery. We needed more evidence in patients admitted to our medical intensive care units. And the evidence came later with this study with 50 patients, again, with a correlation between the B-line score against the PICO. And again, it showed a close correlation between the lung ultrasound score assessing the B-lines and the quantification or estimation of the extravascular lung water with a high degree of correlation. And this is another study which also showed a correlation both experimentally and clinically. So on the left side, this is an experimental study which was run on pigs, and it assessed the degree of elevation in lung water by quantifying the B lines and estimating the extravascular lung water, and there was a strong correlation. And when another study was run clinically on patients using the thermodilution technique, patients with acute lung injury and ARDS, there was also a strong correlation. So we have enough data to tell us that there is a correlation between the quantification of B lines and the degree of elevation of the extravascular lung water. But I personally believe that one of the most important uses of lung ultrasound is its high sensitivity. Rather than taking it very enthusiastically into diagnosis, one of the most powerful uses is that its ability to rule out the presence of lung water. And this is an editorial that we wrote on an interesting patient who, it was a case report of a patient who presented to the accident and emergency in a hospital in the States, and he had only very mild symptoms. His oxygenation was not really compromised. ECG did not show any significant abnormalities, but the emergency physician was quite used to do lung ultrasound. And when he put the probe on the lungs, he saw bilateral curtain-like pattern of frank edema and increase in extravascular lung water. So this was a trigger for him to call his cardiology colleagues. They did further assessments, and the patient was taken to the cath lab, and they found a critical left main occlusion. And when they measured the LVEDP in the cath lab, it was very high. So the message here is that even if the patient does not have significant symptoms, you can use lung ultrasound with power to assess the early changes in extravascular lung water by looking at the number of B lines and the degree of elevation and the change in the pattern as we saw before. And here we looked into the correlation between the lung ultrasound findings and the CT scan findings in patients with COVID-19. We all used a lot of lung ultrasound during COVID, and we saw how useful it was at the bedside. And we saw that there was a correlation between what we saw on the lung ultrasound, especially when they have a patchy degree of curtain B lines pattern or the rocket sign, as correlated to the ground glass opacification on the CT. And again, this was a useful reminder that this can be used as a powerful monitoring tool at the bedside. So I think, as highlighted by Ashraf, integrated approach is key here. We should not rely on one modality, and this cannot replace our common sense. We need to use all the tools we have, scanning the parenchyma, scanning the pleura, the IVC, scanning the neck veins, and after assessing the patient and putting this in the clinical context, we hope that we have the right approach for the patient after that. So I will finish by mentioning some of the limitations. Any diagnostic modality has limitations. Lung ultrasound, as we heard as well, cannot provide a quantitative assessment of lung water. It can give us an idea about the degree of elevation, but without the same power as compared to the PICO or the thermodilution technique. Lung ultrasound cannot provide a comprehensive picture of both lungs. So it can give us an idea, but again, CT chest remains the gold standard. So we have to know our limits when we use the modality. It can miss deep abnormalities within the lungs. And of course, we are hoping and waiting for more data for further validations of those observations. So I will finish with those 4 take-home messages. I think that B lines can be the sonographic biomarker of lung water, and lung ultrasound could be useful for the evaluation of the extravascular lung water. And I hope that you agree with me at the end of this presentation. Integrated approach is a key here. One modality is not enough to give us the answer to our patients, and lung ultrasound should be used in the clinical context. And I think we are witnessing an era of personalized management. We are changing our approaches from the old protocolized care into more personalized approaches. And ultrasound lies at the forefront of tailoring what our patient needs. So that's the end of my presentation, and thank you.
Thanks very much, Dr. Hatem, and as usual, a comprehensive lecture and very informative. So just one quick question, because as we know, extravascular lung water is correlated with higher mortality. But to your knowledge, is there any research done evaluating the lung ultrasound in relation to mortality and morbidity benefits or ICU stay, mechanical ventilation days, or anything like that?
No, I'm not aware of any robust evidence on the correlation to mortality, I'm afraid. I'm not aware of that.
Perfect. So I think it's one of the evidence that's still like running in the background, and hopefully soon we'll find something, because it's genuine and it's legitimate to use ultrasound in assessment, but the evidence is still cooking there. I hope it is. I think so, if you agree with me.
Yeah, we definitely hope so. I think as we all know, it's an evolving field, and we are hopeful that the future will bring more validation and more robust data on the modality.
Perfect. I will check if we have any more questions from our colleagues here. So, okay, so question from Hassan Ibrahim, a quick one. Is there any score for assessing lung condition? Is it wet or dry? Something like lung score with pneumonia?
Yeah, there is a lung ultrasound aeration score, which was initially developed by Belaid Buhamat. It's one of the useful scores that was used in several recent studies on assessing the recruitment of patients on mechanical ventilation with ARDS, and also recruiting patients after anesthesia and after surgery. So the score, there are two versions of the score. The simplest version is giving a score of 0 to the A line, normal aeration, score of 1, the non-confluent B lines, if we may call it that way, score 2 to curtain-like pattern confluent B lines, and score 3 to the consolidation. So this is the simplest version of it. There is another more detailed version. You can look it up, and I might put in the chat box the paper for them to have a look. So looking at the score can give you a tool to seeing the changes in the aeration along the hospital and ITU stay, looking at the response to recruitment. And we use that actually in patients with COVID-19 coming to us, especially those who came with a full-blown ARDS picture. And it was quite useful.
Perfect. I think it was highlighted by Dr. Ashraf Tayyar in his lecture as well, lung aeration score. So thanks very much. We will go ahead now and proceed to the next lecture,